welcome to this webinar, namely the pioneering pathways implementing shorter TB preventive treatment regimens, populations at risk, and more. Over the next 90 minutes, we will have an opening with a poll you will find in the chat, followed by 3 country presentations, specifically from Indonesia, the Republic of Tanzania, and Ethiopia. This will be followed by some questions and answers. We will then move to some more global perspectives on implementation research regarding TPT, TB preventive treatment, of course, and particularly 3HP and shorter regimens. And this will be followed by some policy and practice discussions on involvement of the private sector in programmatic management of TB preventive treatment. This will be followed by further questions and answers. We will highlight why TPT is important globally, of course, to be able to achieve the elimination of TB we aspire to, and the reduction of morbidity and mortality, and also to catch up after the when we had COVID-19, a lot of the TB services were disrupted, and therefore we have to accelerate our efforts, and TPT is one mechanism to do that. My co-moderator will give you a broader overview of the IMPAACT4TB project, which started in 2018 and had 12 countries participating to accelerate as early implementers the rollout of shorter regimens and to demonstrate this can work and the benefits. And KNCV, who I represent, was involved with 4 of the 12 countries, namely Indonesia, Tanzania, Ethiopia, and Malawi, and 3 of those countries will present, as I mentioned. So I would now like to hand over to my esteemed co-moderator, Makaita Gombe, who is the director of the IMPAACT4TB project from the Aurum Institute in South Africa, and she will provide a brief introduction into the project, and followed by introducing the country speakers. Thank you so much.
All right, thank you very much. Thank you very much, Jerod. Just checking with everyone, can you see my screen properly? It should have my name on it. Yes, okay, thank you. As some of you may know, if you've been following the project over time, we had initial guidelines from the WHO that recommended short course TPT. So this introduced 3HP, which is 3 months of rifapentine and isoniazid, taken once weekly. There were also other options in there, 3HR, again, 3 months daily of isoniazid and rifampicin, and then 1 month of isoniazid and rifapentine, which is 1 HP. We have since received new guidelines from WHO that were released last week that also include dosing for children. Initially, we couldn't dose in children under 2, but now we can also dose for children from 0 to 2 years old, all the way up to adults. So, and at the time when this project started, TPT uptake was about 49%, according to the Global TB report from 2019. So as you can see, we really were not, moving in terms of preventing TB, and yet we still had high mortality from TB. So what was this project supposed to do? This project really was looking at, as we were introducing 3HP, we had INH for 6 months for a few years before that, and we were trying to introduce a shorter TPT regimen. But there were questions around, can this actually be used among people living with HIV? Can this be used among people living with HIV that have just started taking ART? There were questions around this dosing that we just mentioned for children under 2. And how do you do this? If it's going to be shorter, can you initiate it from the community level? Does it all have to be done at facility level? Does it have to be done by a doctor or by a nurse? So these were all questions that we had at the beginning. So as the Aurum Institute, we led this project generating evidence for practical usage. So the first one was a clinical trial, the Dolphin study, which looked at the safety of co-administration of 3HP and DTG-based regimens. And this was proven to be safe. And only then did we start the rollout of 3HP TPT among the 12 countries as mentioned by Jerod. And then the next part was really answering the question on which was then called Dolphin 2, 3HP in ART-naive people living with HIV. The study was concluded and it showed, again, safety and consistent viral load suppression among people who are newly initiating on DTG-based ART. So then that information has now been published and is available. For the next study, TBTC35, which was done in collaboration with the DTTC in Stellenbosch, they also then managed to find the appropriate dosing for children under 2. So you can now look at a family approach. If everybody in the family is living with HIV, the whole family can get shorter course TPT, for children, including children. And then in terms of service delivery, we also had a study, CHIP-TB, that was investigating TPT in general, not just 3HP, among child contacts, whether or not this could be done within a community setting. I won't speak much about that. Christiaan will speak about it later. And then we also had another study which was looking at how do nurses initiate TPT within ART clinics without increasing their burden or their load of implementing TPT. So this was another study and evidence that was generated within this project. And then there was also a question on supply side interventions. When this project started, we only had one supplier and they had very little capacity. We have since managed to increase the number of suppliers, reduce the price of the product in order to increase uptake of short course TPT. At this point, there were still gaps in evidence. Can this product actually be used by children on DTG-based ART? So the study that I mentioned earlier, Dolphin, was in adults. So we're conducting the same study in children on DTG because you cannot assume that the way drugs are processed in an adult's body is the same as they're processed in a child's body. So we are conducting this study. We also have a study among pregnant people. We're evaluating both 3HP and the shorter 1HP, which is once daily for a month, in pregnant women with HIV. Again, we also expect the results mid next year, and we should be able to close those gaps among key populations where evidence was not available. We also have another study, 123, which is comparing between 1HP and 3HP. We often get questions, which one is better? This one is really just looking at, in terms of completion, is one completed better than the other? And then in terms of adverse events, does one have more adverse events than the other? We also looked at, just because of the formulations we have, there were some countries that initially we didn't have a pediatric formulation, so there were some countries that wanted to use the adult formulation to give to children. So we also did an assessment, again with the Stellenbosch University, looking at children, of whether when children take the adult formulation crushed, will they still have the same amount of medicine in their body as when it is swallowed whole, as what an adult would do. So that one has just completed, and we should be publishing results on that soon. And then the last one is really, over the course of the project, we did manage to then get a pediatric formulation developed for use in 3HP in children. And we're now conducting an initial feasibility study in 3 countries to see how this would work, how would caregivers use this, does it actually taste well for children, can they tolerate it? And then this is just a summary of what we managed to achieve in the project so far. The price of 3HP at the beginning was at $72. It has since come down to $9.99. In terms of manufacturing capacity, I know right at the beginning of the project, so countries that started rolling out 3HP at the beginning would have had supply concerns. We also had nitrosamine issues at the time, but since then, all of this has been resolved and manufacturing capacity has since increased and orders are moving in smoothly. They're not long lead times anymore. In terms of global uptake, over 10 million patient courses have been procured across 99 countries. And, we have a lot of the communities that we worked with to thank for this, that really worked on demand generation, busting myths within the community. And then the bottom right quadrant is really just the suite of formulations that are available. We started off with just that one product. And then now we have, an FDC, we have 300 milligram singles that also work for 1HP, and we have a new pediatric formulation that will be coming onto, that has come onto the market. And then, so this is really a question for most of you implementers on the call. We have now all of these different options that can be used to make up 3 HP or 1 HP. And there are questions that have come up from implementation. There's really mixed feedback. Is 1 HP preferred? Is 3 HP preferred? We found in one country that is implementing early 1 HP. In the urban areas, there was a preference for 1 HP, but in the rural areas, there was a preference for 3 HP. Currently, the pill burden is the same. It's 3 pills, whether you're taking the 3 HP arm or the 1 HP arm. But then there are questions around, is there preference for a 1 HP FDC, which would then take into account the full dosing in 1 pill per day for 28 days? Or should we co-pack what we have is currently is the 300 milligram singles and an FDC, put them in 1 pack, and then a nurse has an option to either give 3 HP or 1 HP to a client based on what their preference is. So this is a question really maybe we can ask at the end of it, like which is preferred, and then we can see if it's possible to actually bring it to market. And then lastly, just talking about the pediatric formulation that I mentioned. So as part of this project, we do have some products that we're willing to offer to countries to learn initial lessons on, do you actually, how does this work within your supply chain system? How does this work programmatically, for the children within the program so that they can benefit from a shorter, once weekly dose of 3 HP. So currently we have about 1 million tablets on offer, which is about 27,000 patient courses roughly. And you're able to then reach out to us, apply for it, and then the order should be placed through GDF. So this is just an opportunity for everyone on there in case you're interested. And just lastly, this project was funded by UNITAID, still ongoing, and these are the partners that we worked with. And would also like to thank the ministries of health that we worked with in the 12 countries and the communities and patients that took the product. Thank you. So at this point, I would like to hand over to Dr. Yere from Indonesia. So Dr. Yere has worked on the IMPAACT4TB project in Indonesia. He has a background in medicine and some years of clinical practice. And he shifted to the public health sector a few years ago with 7 years of experience in NGOs. He has been managing numerous projects in TB and HIV, including the introduction of new treatment that has been widely used across many countries, which is mainly the 3-month regimen for latent TB infection and 6-month regimen of BPAL-based regimen for DRTB. So over to you, Dr. Yere.
Yeah, thanks, Maka. Yeah, thanks, Joan. Hello, everyone. Good morning, good afternoon, also night. My name is Yeremia Runtu. As mentioned by Maka, I'm from Yayasan KNCV Indonesia, or known as KNCV Indonesia. Thank you for having me, and it's an honor to share Indonesia experience to adopting and expanding shorter TPT regimens, 3 HP. And we would like to express our gratitude towards KNCV TB Plus and Aurum Institute for arranging this opportunity to share and learn TPT short regimen from other countries too. Okay, let me start with the Indonesian country context. So yeah, we have 277 million and categorized as upper middle income countries since last year. But unfortunately, we also has the second highest TB burden globally. Not mentioned also with the HIV-associated TB and MDR TB as well. The trend for TB notification were relatively constant from 2010 to 2016, increase in 2018 and 19, but decrease in 2020 and 2021 due to COVID-19 pandemic, but increased again in 2022 and 2023. The highest coverage in treatment coverage in 2023, last year at 77%. However, the coverage of TPT, both for household contact and PLSIV, remains low, as you can see on the bottom right corner. As of now, in 2024, the achievement for household contact is 9.8% versus 88% for the target, and 9% for the PLSIV versus 55% for the target. Okay, next slide, please, Juan. Can you move the slide, Jerod?
This is Juan. Jerod, could you please take control of the slides? Perfect,
Okay,
thank you.
Thanks, Jerod. Yep. The TPT provision began in Indonesia 2012 using the standard 6/8, 6-month daily isolation regimen, and 2016 the regimen included the children under 5 years old. 3 years later, 2019, the IMPAACT4TB project come to Indonesia as part of many countries and introduced a shorter 3-month INH and rifampicin weekly doses and known as 3HP. In 2020, Indonesian NTP, sorry, Jerod, can you move to before this? Yep, the policy context. Okay, thanks. Yeah, Indonesia has developed necessary policies, including the PM-TPT guideline for the PLSIV, household contact, and also the population at risk, such as the healthcare workers, prisoners, people who live in a high-risk congregate setting, such as the boarding school and etc. In order to successfully implement the short-term TPT intervention, there are numerous issues that must be resolved. The first one is, of course, the policy. And at that time, there is no PM-TPT guideline established in Indonesia. Regarding the human resources, of course, there's limited understanding of PM-TPT or TB infection among the healthcare workers in Indonesia. In terms of resources, there's currently no information, education, or communication materials, IEC materials related to the TPT, only for the TB active management. For the logistic, rifampicin was not available yet in Indonesia at the time. The surveillance system also, the variable related to the TPT still stick on the 6/8, not yet for the 3HP. And lastly, but most important, is the public awareness that still lack of awareness of the TPT advantages among the community. So how do we intervene the issue during the IMPAACT4TB project in Indonesia? We help NTP, MOH to develop TBI and PM-TPT guideline according to WHO recommendation. We support training for healthcare workers, including professional organizations such as the internists, pulmonologists, pediatrician, and healthcare personnel that work in the primary healthcare, we namely is puskesmas, and also the hospitals. We also conduct TPT workshop for the community from the HIV community, TB and HIV community. For the IEC materials, we support NTP and health offices to develop the information, education, and communication materials, such as the pocketbook and the leaflet. And to ensure the logistic, the IMPAACT4TB project through YKI donate the 25,000 doses, I think for 2 batches, to support, to generate evidence in Indonesia how to adopt a new technology relating to TPT. For the surveillance system, of course, we support the NTP information system to accommodate recording and reporting variables related to the TPT. So we add 3HP as one of the TPT option. And after all the factors, enabling factors is in place, we starting use the 3HP in capital of the Indonesia is Jakarta, and then expanding to other 5 provinces. And beginning December 2020 until 2021, 53 PLSIV and 103 household contract enroll on 3HP. What we found along the way while implementing the TPT 3HP regimen, such as the limited understanding and engagement among the community, the logistic barriers, not the drugs, but the TST, what we found is TST, I mean, is sufficient in national level, but not in provincial or district. I think this is due to the lack of supply chain mechanism. And for the chest X-ray to opt out the TB active, still not yet covered by the government through the National Health Insurance Scheme. For the service delivery perspective, there is no standardized SOP, standard operating procedure, available in the health facility level regarding the TPT implementation. And lastly, for the surveillance system, we learned that we have to add the drug safety monitoring modules in the NTP information system. Okay, what was achieved in the end of the project? So despite the challenges, there's been significant progress to adopt 3HP as one of the option for the TPT among the household contact, PLS-IV, and other risk group in Indonesia. The first one, so among the 103 patient household contact, 94% is the completion rate. And for the PLS-IV, even better, 98% was the completion rate among the 53 PLS-IV. We developed the pocketbook, not for the healthcare workers only, but also for the healthcare cadres training. And this initiative helped enhance the understanding and TPT among for the workers, healthcare workers and community. And for the patient, we use also the flip chart that could be used by the healthcare workers to educate and persuade in positive way to the client. And also we involve the healthcare care worker for the capacity building and also the community. So many of them have been exposed to the 3HP update in 2020 until 2022, I think. And the module has been adopted by the NTP as the standards module and keep being updated to meet the needs of all provinces in Indonesia. So how about now in Indonesia? So we're still facing several challenges. So for the first is the low contact investigation, the low CI coverage, only 26% were investigated according to the MOH NTP data, and around 39,000 were tested, and only 237,600 received to TPT. And so that's 3% of the eligible population. And based on the recent study, actually I do the study this year in one district near Jakarta. One of the cause of the low of coverage of CI is the contact tracing has not been done in the index cases among hospitals. The second problem is the stock out and supply chain issue. Based on the same study, it was found that only 37% primary health center have the TST logistic because Indonesia have to do the TB infection testing among the household contact above 5 years old. So the TST is still lacking, and only 14% primary health center have current TST logistic for the rest of the year. So the lack of coordination between national and local health authorities is still challenging for us. For the community side, from our colleague from the US at Prevent TB done in 5 areas formative study, one of the barrier is among the client and high-risk group is low perceived risk of becoming infected by TB. And this leads to poor acceptability of TPT, such as the negative attitude, burden for the healthcare workers, lack of intervention coherence, lack of perceived effectiveness, and concern about the risk of drug resistance. From the policy point of view, I said before that the chest X-ray and also the TST has not been covered by the National Health Insurance Scheme in Indonesia, although the national coverage has been covered by the TB active treatment, not yet, but for the TB infection. And lastly, the current problem is TPT services not yet involving the private sector. So this is Indonesian homework to expand the coverage of the TPT. What we see for the future is right now the WHO and our NTP has adopting the active case finding and white mass screening, and we must integrate the TPT and in those prioritized activities, and it can be crucial to identify the individuals with TB infection as well. The second, of course, we must strengthen the contact investigation mechanism. In the currently the NTP update the technical guideline for the contact investigation, and we'll adopt the 717 scheme that WHO operational handbook that recommend, but in more local context. And of course, the homework is to expand the TP in private sector, to advocating also the National Health Insurance Scheme. In Indonesia, it's called BPJS Kesehatan, to cover the TST and chest X-ray examination. And lastly, we must tailoring communication and awareness campaign. Effective communication is essential to increasing awareness and uptake of TPT, especially for the household contact, since they are feel healthy before know that they are positive either TST or IGRA. What we learned in the project from the health offices, we see some good practices. They funded TPT capacity building for the healthcare workers and cadres for the internal updates and funded by the domestic budget. For the community level, we collaborate with TB and HIV community, and it is essential to raise awareness for acceptance throughout the nationwide. And lastly, in the health facility level, one of the hospital involve psychologists to improve TPT acceptance among PLS-IV, and the CST clinic also do the one-stop service. So the PLS-IV just stop by in one clinic and receive both ART and the TPT. I think this is my last slide. So in the last, I would like to give our gratitude for this project appreciation to Ministry of Health Indonesia, the NTP and NAP team, healthcare workers, CSOs and communities, also cadres, donors and partner organization, people and communities affected by TB and their family, and also special thank you to UNITED, Aurum Institute, KNCV TB Plus, and IMPAACT4TB Project. I think that's all for me, Jerod, and happy to take question. Over to you, Maka.
So,
oh, Jerod, thanks. Yeah.
Yeah, this is a very impressive presentation. I wanted to say that it looks like things have really snowballed for your country. You did a pilot demonstration project, and then it went to scale on a national level, and now the national counterparts have taken over. So that is very makes it look more sustainable. There are a few questions in the chat. One of them was, what are the reasons for low TPT coverage in Indonesia? And I wanted to point out that while the contacts and the people living with HIV, the coverage is much lower than the target. It increased exponentially despite that. But maybe, Yera, you can briefly comment to that. Yes,
yeah.
Thank you.
So it is. It was for the PLS-IV coverage, right? The TPT coverage among PLS-IV.
And for contacts, yes.
Oh, for the contact also, yeah. Yeah. So one of the biggest problem in our program is the low contact investigation. So I didn't mention before that not all the provinces have their own health cadres. So yeah, because not all the healthcare workers can do the services outside the building. They have been busy for the services inside the building. So yeah, we need many cadres, and this is one of the government commitment in the new decree, I think, from the president and also the minister to recruit more cadres, especially in the working area that has not been supported by the Global Fund. And the number two, and of course the acceptance from the community, because the healthcare workers, and also the logistic is there. Not only the 6H, but also the 3HP and 3HR is widely available across the nationwide. And right now is our homework to educate more, not only in the healthcare facilities, but also in the public space. And that's our colleague in the USA Preventive TB also do the communication strategy. And I think this year or early next year will be launched nation. I think that's the interim comment, Jerod. Thanks.
We will now move to the presentation from Ethiopia. Mr. Taya Leta is a senior public health specialist with a master's degree in public health with 23 years of experience in the field, and he is currently the National TB, Leprosy, and Other Lung Disease Program Manager and lead technical working group of TB, leprosy, and TB HIV prevention and control since September 2017. Mr. Leta will be accompanied by Dr. Ahmed Bedru, who is the Executive Director of KNCV Ethiopia in the discussions, but Dr. Leta will present his experiences rolling out shorter TB preventive treatment in Ethiopia. Over to you, Dr. Leta.
Thank you so much. Thank you, Mr. Chair. I'll share you the practical experience of Ethiopia, which in the past 4 years, based on that, my presentation outline is like this: the country context, policy context, and what were the problem to address for the rollouts of the short regimen, and how did we approach the problem is also some of part of my presentation. So when we come to the country context, especially Ethiopia are one of the countries that found at the Horn of Africa with a population of 129 million currently. So Ethiopia is among the 30 high TB and the TB HIV countries globally. So the incidence is actually it is around 126 per 100,000, and that lead around 156,000 TB estimated TB cases in a country. So the TB mortality is still stand at 17 per 100,000, with an estimate of around 21,000 of TB cases annually. Concerning the MDR TB service, it is around 2,000, with the estimation of global TB report in 2023. The other one is that the policy context. Actually, TPT policy before the IMPAACT4TB projects in Ethiopia is that almost it is INH or IPT for the 6 months for people living with HIV, and children under 5 years contact of bacteriologically conformed TB cases. Then national tuberculosis and HIV program management of LTBI developed an addendum, and in March 2020, and that addendum have most key updates on that addendum. So new alternative for TPT regimen have been included. That is mainly the 3HP for the those age greater than 2 years, and for children less than 2 years, again 3 RHs for age less than 2 years, as well as for children less than 15 years also. The targets or eligible group is also expanded at this period during the development of addendum. People aged between 5 and 15 years who are HIV negative and who have been exposed to index case with bacteriologically conforming pulmonary TB is one of the eligible and expanded age group at this period. The other one is update to the recording and the reporting tools to reflect those updated alternative regimen, and eligible group is one of the areas that included in the addendum. So the addendum also provides the guidance that is consistent with global WHO recommendation of 2018, and it is considered the feasibility of option for the management of LTPI in the context of Ethiopia. So yeah. What were the problem to address for the rollout of shorter course regimen at this period? Actually, in Ethiopia, only 49% of the people living with HIV newly enrolled in care, and only again 22% of under 5 children who are contact with bacteriologically conforming pulmonary TB cases were started on IPT, because it was around 6 months regimen, and even it is length up to 9 months for people living with HIV. So this is main challenge, and other one is the country has continued its commitment to ending TB, enhancing the concerned effort to achieve the minimum target set with UN high-level meeting to provide TB preventive therapy to a total of near to 500,000 high-risk individuals between 2080 to 2022. So the other one is that unavailability of WHO recommendation for 3HP at the early phase of project startup is one of another challenge, and other issue is that high cost of 3HP at the initiation period is another challenge. So government is not ready to need for the donor support for implementation, and limited amount of refund support through IMPAACT4TB is another challenge. So there is only at the pilot implementation areas. The other one is need of waiver for importation of rifampicin, and the need to include in the essential medicine list is another time taking. That is the challenge at that period, but currently it is not a problem. And the need to include into the integrated pharmaceutical and the logistic system is another issue, because sometimes it is revised every 3 years. The other one is need for the integration of 3HP into the reporting system, electronic reporting system, such as DHIS2 is another challenge. So what is an achievement, especially what was achieved in the end? Ethiopia adopted the global TB prevention recommendation with the aim to address the end of TB strategy and the guidance, the implementation of TPT in eligible population. So far, Ethiopia has been implementing TPT for people living with HIV and under 15 years age contact with bacteriologically conforming pulmonary TB. The other one is that for the shorter regimen, 3HP scale-up was nationally launched in May 2022 in Ethiopia, and MOH, especially the ministry, put the procurement order for loose rifampicin in global fund for the year of 2023 and beyond. and as well as almost all TPT regimen integrated into the national HMS and disaggregated by TPT regimen both for HIV and the TB. And another achievement is that integration into the existing IPLS system, that is quantification with global fund budgets, integrated distribution for the fixed dose combination for people living with HIV, and rifampicin for children contact is one of the main achievements. So based on that, the TB preventive treatment progress, that is the national TB program performance shows that the TB enrollment is among under 50 years household contact is improving progressively. So that means here in almost in 2019, we have only 9,740 enrollment, and when in 2023 we reached around 55,518 children is enrolled into the TPT with 3HP as well as 3RH. That is the main success. And other one is that here, this is the progress to the against to the UN high-level meeting target. So actually, as I said, it is very minimal in 2018, and we reached around 55,000. When we compare to the UN high-level, still it is low, but we achieved more than 60% of the UN high-level meeting. That is the main achievement. And other one is that TPT acceleration campaign also conducted for people living with HIV, especially there are a backlog for people living with HIV. So as this period, again, we conduct the TPT acceleration campaign. So that is, there is identified baseline for TPT program status and made a realistic estimation for TPT coverage gap. So that's based on a midterm performance of the TAC showed that TPT coverage gap is for the same cohort is shrinking to 35% at the 6 months. So that is the gap is actually narrowed. And compared to the baseline, monthly TPT uptake is at the TPT acceleration campaign site increased more than tenfold within the 6 months. That means from 238 versus 2,768 per month. A total of 11,825 existing and newly enrolled clients received TPT during this period, and which is a 5-fold increment compared to the preceding semi-annual performance. So here, this is a period where the TPT acceleration plan is performed, and at this period, the TPT among people living with HIV is increasing, and again, the completion rate is also increased. Here it is a time where TPT improving plan is also initiated, and TPT coverage among people living with HIV is increased. The other one is that what is the next is that mostly currently there is a plan for UN high-level meeting and national level strategic plan. So the current TB leprosy and other lung diseases has a plan to expand and implement TPT for eligible target group, adult household contacts, and clinical risk group, and high TB transmission setting from July 2024. So based on that, Here, TPT contact for about 5 years. We are planning to around 308,000, and for children, again, under 15 is also planned, like for under 5 children is also planned for the next 4 years is around 181,000. The other one is that's plan toward meeting of the NSP targets. Here it is around for TPT contact above 15 years is around 319,000, and for children below 15 years is planned for 289,000. So these two together is around 600,000 within the next 4 years is one of the plan. The other one is that the challenge along the way. The first challenge is that delay on the project implementation and the 3 HP deliveries, the main challenge. And second one is the global shortage of rifampicin, that is 3 HP drug production and distribution is the main challenge. And in between, there is a challenge with COVID-19 pandemic, low production and the capacity of pharmaceutical logistics is one of the challenge. The other one is the report of nitrosamine impurity is one of the challenge, and the fourth one is utilization of loose formulation for children pills burden to child and caregiver is another challenge. The other one is sustainability of support at health facility and the frequent stockouts, expiry of low volume item like INH 100 milligram for children, and facility do not report and request 3 HP during drugs like a simple quota system and push. Also true for INH and 3 RH vitamin B6 is main challenge. The other one is attrition of trained health providers, healthcare workers, and the staff rotation is main challenge. The other one is that the remaining existing challenge is still, the first one is still loose formulation for children with cause of pill burden is the main challenge still, and other one is the 3 HP not recommended for children under 2 years is another challenge, and the 3 HP not recommended for pregnant women, and the cost of rifampicin is still high when we compare the other two drugs. The other one is the lesson we learned during the process is that integration into the existing system and the guideline is very important, and that can cause early implementation of the shorter regimen. And the other one is the national scale up along with integration of 3 HP community into existing IPLS systems can facilitate the implementation of shorter regimen. The other one is the need for a strong follow-up during initiation of a new implementation for any type of drug is very important. So that is what we learned, and way forward, implementation of TPT for all household contact and the other risk group is one of the main plan for us, and expansion to risk group is also the main area. And the second one is implementation of TPT for drug resistance TB contact, like levofloxacin for 6 months is another plan, and the implementation of 1 HP in prison setup is the other plan, and improve the TPT coverage to achieve the UN high-level meeting and the NSP target is our next plan. So here, this is all what I have Thank you so much. This is my acknowledge to the United IMPAACT4TB KNCV, as well as Aurum Institute, Ministry of Health and Health Facilities. Thank you. Over to you, Chair.
Thank you so much, Dr. Leta. This is a very impressive, also similar to Indonesia, that you started as a pilot and then you snowballed to great levels and achievements in terms of reaching contacts, expanding the contacts and the risk groups. So over to you, Dr. Neema. I will introduce Dr. Neema, is going to talk about the practical experiences from Tanzania, rolling out shorter TB preventive treatment there. He is the program coordinator of the National TB HIV Program in Tanzania. He has been deeply involved with the rollout of shorter TB preventive regimens in Tanzania, and he's fostering partnerships to achieve the targets established by the UNHLM and by the National Strategic Plan. Over to you, Dr. Neema.
Good morning, everyone.
There you are.
My name is, you can hear me. So my name is Dr. Peter Neema. I work with the Ministry of Health Tanzania and the National TB and Leprosy Program. And I'm responsible for coordination of TB comorbidities, including TB, HIV, and TPT provision. And on behalf of our Permanent Secretary and Program Manager, I would like to convey many thanks from our country to KNCV for their continued support and for their invitation in this meeting. And today I'm going to talk about Tanzania experience in the implementation of shorter TPT regimens. Next slide, please. So here is a list of abbreviations. Next. Tanzania is among the 30 high TB burden countries, particularly to TB and TB HIV burden is within those high burdened countries, with a population of around 60 million people as per last year census. And the notification 2022 was around 101,000, and in 2023 was around 98,000. Tanzania started the provision of TPT in 2007. It started with under 5 household contact of PTB patients, and then moved it to PHIV in 2011. And is currently offering TPT to these two groups, though it is planning to start the rollout to other groups in the early next year. Concerning the achievement of UN high-level meeting targets, as you can see, for the UN level high meeting target of 2018, the target was 119 for under 5, 176 for other household contact, and for PHIV was around 573. And the achievement in PHIV was around 222%. And for under 5 household contact, it was 52.5. And for population above 5 years old, we have not yet started. We are planning to start it next year. Next slide. And the target for the current UN level meeting 2023 to 2027 is 1,080,000, and it's still under implementation. So in the year 2021, around in November, the Permanent Secretary Ministry of Health formulated the National TPT Expert Committee following to various implementation challenges like adherence, uptake, fluctuating commodity, and supply. The committee is comprises of national TPT experts from the Ministry of Health, from the President of the Regional Administration and Local Government, from National Institute for Medical Research, Medical State Department, development partners, implementing partners, and civil society organizations, just to mention a few. And the National TPT Expert Committee, since its start, has delivered the following deliverables. First, it reviewed the literature and other existing evidences, and it came up with key recommendations, which were to start the rollout of new shorter TPT regimens to within the country, and also to provide TPT to other at-risk groups like prisoners, minors, people who use drugs, and population above 5 years old. And also NTEC developed the National TPT Scale-Up Plan to guide it on its implementation of TPT in the country. The National TPT Scale-Up Plan had a costed roadmap and a transition plan. And also the NTEC did the forecasting, quantification, and procurement of commodities. Next. So along the National TPT Scale-Up Plan, the National Scale-Up Plan had 4 phases. The first phase was a planning phase, which took place from November of 2021 to the second quarter of 2022, and also pre-implementation phase from 2022 to 2023, routine implementation and scale-up, which started this year, and also we are planning to conduct a program evaluation at the end of the next year. So in short, during the planning phase, the NTEC did review the literature and came up with the recommendations, which I've already talked about. And it also developed the TPT Scale-Up Plan, transition plan, and also the forecasting. And during the pre-implementation phase, the NTEC developed the tools which could be used there during the rollout. The tools were like guidelines, job aids, training package, reporting, recording, M&E framework. Also, it did the updation of M&E databases from PHIV, for PHIV and for TB, and also capacity building. The NTEC also, before the rollout, liaised with NIMR, Mbeya, and Muhimbili to conduct the operational research implementation on TPT implementation feasibility, and it came out with a report which helped the ministry to decide to roll out on the new TPT regimens. Next slide. Now I would like to take you through the TPT strategic initiatives, which was supported by Global Fund, KNCV, and the WHO. KNCV was contracted to provide the technical assistance with the WHO through the support of Global Fund, and the strategic initiative for Tanzania had 6 key main areas. The first deliverable was to provide to formulate the M&E plan for TPT rollouts, and also another deliverable was to develop TPT M&E tools, which has been done, and also updation of databases for TB and HIV programs to update new TPT regimens, and also TPT training packages were developed and total training was done, and also capacity building to all healthcare workers, almost 50% of them has been done. And also there was a development of IEC material for demand creation, and printing and distribution of IEC materials was done. Also, WHO TB Prevent app was adopted to ETL, and also Unity TPT package was also adopted. Next slide. Among the challenges which were faced during the implementation of the National TPT Scale-Up Plan was the lack of pediatric friendly formulation for 3HP. This was in 2021, but recently we have heard that it's available, so we are contemplating on to its rollout. Also, limited adoption of diagnostic tools. Currently, the country is not conducting TBI testing among at-risk groups because of prevalence issue. We still don't know the prevalence, so we are also planning to conduct the prevalence study if available. But according to WHO, they say that if TBI testing should not be a limitation, so we will carry out the new groups for receiving TPT without TBI testing as of now. That is our plan. Also, another challenge was the capacity building for dot providers at TB clinics. You know, most of our partners support HIV interventions, and when they started to support TPT implementation, they focused on the CTC, on their CTC or care and treatment centers for HIV, and few TB clinics were reached. So we were telling those CTC healthcare workers who has been capacitated to also capacitate the TB clinics. That is the modality which we are conducting right now. Also, another challenge is on follow-up and adherence challenges in monitoring the adverse events reporting through the cohort event monitoring. As we all know that cohort event monitoring is supposed to be conducted when a country starts adopting new regimens. So we have already developed this protocol, but we are faced with a funding challenge for its implementation. Also, there is a challenge of stockout of INH, and this was caused by, we were expecting to roll out a new TPT regiment last year, but due to delays, we started the rollout in this year in around January. So the stockout, that was the cause of it, and also there were continuation patient, pregnant women, contraindications to rivamycin are the one who needs INH. Also, another challenge was inadequate recording and reporting due to CTC updates, which has taken place from January to April of this year. Insufficient tools and knowledge, as I've already said, that we've capacitated around 50% of healthcare workers. Next slide. What was achieved at the end of this scale-up plan as of now, the country has been able to roll out shorter TPT regimens since January 2024. That was when the circular was out. So other regions started the rollout in February, others in March, others in April, depending on the preparatory issues. Also, most of NTEC and TPT strategic initiative deliverables have been met. As you can see below in your presentations, we've been able to develop all those stuffs which I've already mentioned. Next slide, please. So what are the lessons learned? We have around 4 lessons which we would like to share with you. The first one is the need to accelerate TPT uptake and catch up with the mop-up campaign. Our country last year, it conducted a mop-up campaign to around 40 days across 26 regions, which were, and the target was to catch up those PHIV who were eligible for TPT but have not already taken TPT. We call it a backlog, and most of them were covered during the catch-up campaign or mop-up campaign. Another lesson learned is the model of using expert committees, which is a mix of multi-stakeholder and different health professionals in programmatic scaling up of TPT. This, I think, should be also adopted by other countries because NTEC did a wonderful job, a highly systematic job during the rollout of new TPT regimens and scaling up of TPT interventions in Tanzania. Also, the country has been able to adapt or adopt the Prevent TB app, the WHO Prevent TB app to DHIS2 ETL. As we all know, DHIS2 ETL is electronic TB register, and also modified community TB hub has been adopted. And this helps to cover around 5% of those facilities who don't have computer resources and also internet resources. And the last operational research implementation research was done to inform the country, and the research was facility-centered and family approach designed. And during those study, the report showed that there was a high uptake and the demand for TPT and the adherence, and this helped to inform the Ministry of Health to scale up TPT and in the rollout of shorter TPT regimens. Next. So what are the remaining existing challenges? I think I've already mentioned them in some point. Inadequate fund for cohort event monitoring, INH stockout, and also insufficient fund for capacity building, also for community health workers and the remaining healthcare workers. Next. So what is the way forward in our country? The first way forward is for the vertical TPT legacy stock management. Currently, we are having a stock which needs to be destroyed, and we don't have sufficient funds, so we are planning to integrate it with the Ministry of Health General Legacy Management for other drugs in all facilities of Tanzania. Another way forward is to develop e-learning platform, and the good news is that the e-learning platform has been finalized recently, waiting for its launching, and also development and dissemination of TPT community package. As we all know, currently we are offering TPT in a facility-based model, and we would like to roll out it extensively to the community system, and also the continuous mentorship of healthcare and community health workers is our way of tackling the challenge of capacity buildings. Also, the scale up of TPT to other at-risk groups. It is expected to take place as a pilot from October to December of this year. It can extend up to March, depending on the availability of resources, and we are planning it to start it in coordination or in partnership with our implementing partners. Also, integration of TB HIV data to be reflected in the electronic TB registered. We would like the key TPT indicators from the PHIV also to be reflected in the TB program, so as to make a follow-up of it and other TB HIV data. Also, timely supply chain forecasting and procurement is our way forward. With that, I would like to conclude my presentation and to thank KNCV and all the partners who have been involved in the support of TPT intervention in Tanzania.
Thank you so much, Dr. Neema. It's fantastic to see that Tanzania has picked up in policy and practice, and there's a lot of movement and uptake of innovations, and congratulations. So we're going to move directly to Dr. Christiaan Mulder's presentation. He's a senior epidemiologist in KNCV Global Office. And without further ado, Christiaan, I will let you go.
Thank you very much, Jerod. Yeah, so my name is Christiaan Mulder. I'm a senior epidemiologist working at KNCV, and it's really my pleasure to share with you in the next 10 minutes some research findings to accelerate scale-up of TPT. So we know that access to TPT is really an issue, and therefore we have developed, or we have implemented two cluster randomized trials to improve TPT service delivery. So the first study I would present on is the CAT study among people living with HIV. And in this study, we tested the effectiveness and acceptability of making TPT the default choice for clinicians in Malawi, Mozambique, and Zimbabwe. So really to make it easier for providers to give TPT. In the second study, that's the CHIP-TB study, and it's in household-child context. And in this study, we tested whether home-based TPT services can improve TPT uptake. And we compared home-based TPT delivery versus facility-based standard of care. And we did this study in Ethiopia and South Africa. And in this presentation, I will present results for Ethiopia. So the CAT study. So as I told you, the idea was to make prescribing TPT simpler. So we created a tool which was linked to ART prescription. And in Mozambique and Zimbabwe, this tool was a sticker which was placed on the personal information of the clients. And in Malawi, we created a default prescribing module, which was built into the point of care electronic medical record. So you see a screenshot of that system here on the right. So the clinician goes through or the nurse goes through a list of questions, and at the end of the consult, the medication which needs to be provided is listed, is ticked. So you see here on the screenshot that also 3HP is ticked. So I jump straight into the results of this study. So during the period of the study, we did not observe any scientific or significant statistically significant differences in TPT prescribing to new ART clients in Malawi or Zimbabwe. So in both arms, around 56% of the people initiated TPT. Whereas in Mozambique, we did find an increase in TPT prescribing to the new ART clients, 87% in the intervention arm versus 71% in the control arm, but this was not statistically significant. And this study has been recently submitted and was led by Johns Hopkins University, and Kate Shearer is the first author of this research. We also did some qualitative research which was nested in the study, and what we found is that there were definitely healthcare workers that perceived advantages of this intervention, because they mentioned like having this default option is lessen their work, so they don't really have to go through very detailed procedures, because it was just built into the system. And also they mentioned that it was acting as a reminder, so that they would not forget prescribing TPT. On the other hand, there were also some disadvantages mentioned of the CAT intervention. Some mentioned that it was reducing their autonomy to make their decisions whether or not to prescribe TPT. And also some healthcare workers, they had some fear for over-prescribing. So they had that which in fact might have resulted in some under-prescribing of 3HP. And this research has been published in BMC Health Services Research this year. So then the second study, so the CHIP-TB study, which was also led by the Johns Hopkins University. So we compared the home-based TPT services versus facility-based TPT services. And in a nutshell, so in the home-based arm, once a TB index patient was identified, health extension workers, which are kind of community health workers, they went to the households of the index patients to identify whether there were any child contacts, and if there were, then they did the screening and so they did symptom screening. And if they turned out to be eligible for TPT, they went back to the health post or health facility to discuss with the TB focal person in that facility whether or not to start TPT. So, and if that was confirmed, then they went back to the household with the TPT and initiated TPT at the household level. And this intervention, this was integrated into 18 other services the health extension workers provided at the household level. So also I jumped straight into the results. So we had the primary outcome was the mean number of child contacts initiated on TPT per TB patient. So we found that there were more child contacts initiated on TPT in the intervention arm, but this was not statistically significant. So on average, 1.7 children were initiated on TPT in the intervention arm versus 1.3 in the facility-based arm. And then in the for the secondary outcome, we just looked at whether there were differences in the number of children identified. And here we also found that there were more children identified in the home-based arm compared to the facility-based arm, but also this was not statistically significant. And this work has been submitted by Nicole Seltzer-Austin from the Johns Hopkins University. When we look at the continuum of care, we found there was no difference in the proportion of children who progressed to the different care cascade steps. However, as I previously said, we did find that there were much more children identified in the home-based arm. So around 91% of the estimated number of child contacts were identified in the home-based arm versus 73% in the facility-based arm. We also did some health economic research in this study, and what this graph is showing that on average it costed $27 to provide TPT in the facility-based arm, whereas this was only $19 in the home-based arm. And what stands out here is that in the facility-based arm, household costs account for 48% of all costs, whereas this was only 8% in the home-based arm. And so there's a clear shift it's clearly reducing the cost for households, the home-based arm, and also you see that there's a bit of a shift or there's a huge shift of costs from households more to the health system. And then we did some qualitative research in this study. So we interviewed caregivers, the health extension workers, the TB providers, and policy managers, and really asked them about this intervention, this home-based TPT services. And some facilitators we extracted was really that this intervention is reducing the burden to caregivers. So the caregivers don't spend the time going to the facility with their children. Also, of course, that was reducing their costs, as I previously showed. I also showed that home-based contact investigation will increase the identification of household contacts. And very important is that this home-based program is really an opportunity for the health extension workers to educate caregivers about the importance of TPT, and also explaining them the differences of treating active TB disease and TB infection. And they also mentioned some barriers. So there were some people who were concerned about whether the health extension workers were really well equipped to do the contact investigation. and to do the screening for active disease. And there were some concerns about health extension workers being overworked and that there's already like a lack of staff. So therefore, the implementation strategies we think are important here is that such an intervention works if there's task sharing between health extension workers and TB focal persons. Secondly, that the service integration should be so the work should be integrated into what health extension workers already are conducting. And thirdly, community awareness campaigns are needed to really improve also the acceptability of this intervention. And then we have a list of criteria or conditions which enable this implementation. And I don't list them all, but clearly education, training, support, supervision to the health extension workers are really critical things to make this work. And more details of this can be found in the publication listed here below. So in conclusion, from the CAT study, we learned that there might be other barriers for TPT uptake among people living with HIV, which might be more important than making TPT the default option. However, we also found that those who used the default option were generally satisfied with this approach. And actually in Malawi, this default prescribing has become the standard of care. From CHIP-TB, we have learned that it's feasible, acceptable, and effective to decentralize contact investigation and TPT management to the household level. And we think that this family-centered approach could really help expand access and increase affordability to TPT for millions of children exposed to TB in their homes. I would like to thank UNIDAID for making this all possible. Of course, the national, regional, district program staff, the study staff. I would like to particularly thank the health extension workers in Ethiopia, and then the other partners in this consortium. And with that, I would like to give it back to the moderators. Thank you very much.
Thank you, Christiaan. This is very enlightening to see how we might increase uptake, including via households directly, and it gives a root cause analysis and some solutions that reduce burden and catastrophic costs for families. So thank you very much. I will now move to Dr. Shri Yellappa to talk about engaging private health sector in delivering short-term TB preventive treatment. Over to you, Shri.
Thank you, Jerod. First of all, let me congratulate all the presenters for sharing the exemplary work. Found very useful. Before I move to the presentation, I would like to set a few questions as a survey, and we really want to know your opinion and voices. So I tried to, as speakers were speaking, I was trying to curate the challenges. And as you can see, there's a community-related challenges for expanding the TPT. There are program-related challenges. And perhaps the most important one is the provider-related. In this presentation, I would like to focus a bit on the provider-related issues. The challenges what we discussed, we know there is evidence. And as far as the private providers' participation is concerned, my earlier presentations did mention about private participation in TPT implementation is quite limited. What we do know is that what are the enablers and challenges for engaging the private sector? Here I would like to ask our audience, what do you think? Is it very important in your country context to engage the private sector for TPT implementation? In the chat, you can have a poll. You will have 30 seconds to vote. Yeah, thank you. Before we go into the private sector issues, I would like to just dwell upon what does this private health sector really means? Because private sector is diverse. It can range from a small solo clinic to a highly specialized hospital, and it varies from countries to country. So in general, the private health sector comprises of all the providers which exist outside the public health sector. It could be philanthropic or it could be for profit, but whose aim is to treat illness and disease. This is the general aim. So I can't see the slides. Can you see the slides, Jerod? I can't see the slides.
Yes, I can see them. Do you want me to take control or?
I can see it's a bit blurred. Probably
it's not blurred from my side.
Okay, fine. I'll go ahead then.
What is the private health sector?
Okay. So I've tried to categorize it into for-profit and non-profit. And formal providers are the ones who are trained formally. And it includes the private laboratories and radio imaging as well. It is for-profit and non-profit. When you look at the informal providers, these are the providers who are trained in traditional medicine, but do practice the other kind of medicine, including the modern medicine, or it could be people who are not qualified, yet they practice. And we have non-profit informal providers who are voluntary healthcare workers. This is the broader categorization of the private sector. Now, I want to know, in your country, are there any policies to engage the private sector? Yeah. So now I go to the issue of when patients have symptoms, where do they seek care? And especially with the patients with the chest symptoms. There are several studies and evidence, clear evidence showing that, especially in the countries from the mixed health systems, around 70 to 80% of the patients, they seek care in the private health sector. And when we look at the number of notification, only 19% of the total cases were notified by private sector. That means we are missing millions of cases which does not really come into the NTP database. There are several studies which also looked at patient pathway, especially where do patients go, where do they seek care, what happens to them. The studies have reiterated again and again that the patient therapeutic itineraries are quite complex, and the whole burden of seeking care, right from the screening to the diagnosis to the treatment, complete the treatment, the onus is on the patient, especially when they reach the private sector. And we clearly know in the private sector, the nature of care is not standardized. And it leads to long cascade of care. There is a high pocket expenditure, and private sector do not have a mechanism to ensure the adherence. So what happens with all this? So if you're not able to engage the private sector, we are going to miss millions of patients, and then we will not be able to get the transmission. So many countries have acknowledged this, the key role played by the private practitioners, and engaging them as a key part of the national strategic plan. Globally, the Global TB Program has been developing many guidelines for TB public-private mix. And what is this PPM is all about? PPM is a strategy to engage the private sector with the NTP so that both together could realize the public health goals. There have been many guidelines developed right from 2010, and there have been many revisions as well. Here, I would like to get your attention to two documents. One is on the roadmap, which is published in 2020, and now it is in the process of getting updated. We'll get a revised roadmap. And the other document is the landscape analysis, which gives you the tools to analyze the private sector. How does your private ecosystems looks like? I would urge the audience to look at these guidelines, which is quite useful to analyze the private health sector. Now let's come at the cascade of care. Which are the stages where private sector could contribute? And there are several evidences coming from the countries with dominant private sector, that if you're able to engage the private sector, they have shown they could increase the case detection, they could reduce the out-of-pocket expenditure, they could reduce the diagnostic delays. However, when we talk about the partnership, let's remember that patient should be at the center of any partnership. Here I'm also introducing the contact tracing, that the TPT cascade. Private sector do have a greater role here. When we look at the different delivery models across the countries, the common model which is adopted and which has been shown effective is to engage an intermediary agent. Who is this intermediary agent who links the NTP with the private providers? They could be a local NGOs, they could be a professional organizations, or it could be a national insurance scheme. We have several examples. I've given it in the examples. If you look at the countries like India, Pakistan, they have engaged the local NGOs and they have purchased the services from the NGOs so that they act as an intermediary or an advocate between the private practitioners and the NTP. They do advocate for the NTP, they provide assistance in the logistics and also assist the private sector in reporting. Several examples also come from engaging the professional organizations. A best example could be Nepal, where they have engaged with the Private Pharmacy Association, where there are many referrals coming from the pharmacies to the NTP. And the Philippines and Indonesia has an exemplary work in engaging the private sector using national health insurance schemes. These are some of the examples of different modalities of engaging the private sector. However, let's also look at what are the approaches used by different countries. One is market-based approaches. You can contract the intermediary agencies, or you can go for social marketing or social franchising. This is the different modalities based on the market. I would like to know what you think, what are the TB PPM policies in your country? Or I think you could also talk about what are the challenges when you engage the private sector in the TPT provision? Maybe I'll wait for a few seconds. I see a few responses coming in. Just in the interest of time, I would like to just move forward. And there are some of the legal and administrative approaches as well to engage the private sector. It could be accreditation, or it could be licensing or market regulation. Another one initiative I would like to emphasize here on the global TB program. It has been TB PPM dashboard has been piloted in 7 PPM high priority countries. And it's planned that they won't expand into the other countries as well. This is one of the very good initiative where the dashboards give you a real-time data on the PPM activities. And you have a private sector has been defined, and there's a typology of the private sector based on the ownership, whether it's a private, for-profit, or faith-based, or also private sector has been classified based on the facility, whether it is primary, secondary, tertiary, and so on. And you have a solid TB PPM indicators. This brings in more of enhanced action into the TB PPM. Here you can see in the service coverage, you have an indicator for TPT as well. That's where private sector has a role to play. Now, let's come to the question of, we have known that PPM has worked and it's effective in engaging the private sector. But how do we make this TPT as an integral part of the TB PPM effort? Or it could be vice versa. Ultimately, we should make the short-term TPT accessible to everyone, whether they seek care in the private sector or the public sector. Let's look at in the spectrum of the activities for TPT provision where private sector could contribute. They could link the population at risk to the NTP. They can screen for TB infection. They could exclude the people with active TB and initiate on TPT and ensure that it's completed. However, the empirical evidence shows that there are challenges in engaging the private sector. Private providers have a lot of skepticism around this TPT provision, and there is a reluctance. There is lack of awareness, and there's lack of access to TB infection diagnostic modalities. And it is again complemented by fragmented healthcare system, which makes the issues more worse. And not necessarily that all the countries have policies to engage the private sector. So what next? What is the road ahead? How do we tackle this issue of engaging the private sector? We really don't know at this stage of TPT implementation globally what could be the best modalities to foster collaboration between public health programs and the private providers, and where we could strengthen the policy framework so that we create an enabling environment for private sector participation in the TPT provision. And definitely we'll have to document and understand what models work for whom and why. So we have been contemplating at KNCV on undertaking a cross-country study and document the TPT policies, do a policy analysis and understand what are the mechanisms are there in different countries to implement TPT in the private sector in terms of human resource in front of funding, or it could be in terms of technology. And we'll have to really get into the nuances of what are the practices of providers. What does that encourage them to engage in the TPT provision? What should be the enabling conditions? What are the barriers? And then probably we'll have to come out with a flexible, a strategic model of care wherein we could engage the private sector in the TPT implementation. Here I would end my presentation, but I would have one question: that what are the kind of recommendations based on your country context, your recommendations on how could we engage the private sector? Meanwhile, you answer these polls. I would end this presentation with, we have all the tools now. We have the guidelines, and we have the top key priorities for action for PPM. We have a TB PPM dashboard, which is very promising. And the last one, we have TB PPM Learning Network. It is a platform, a community of practitioners where we could bring in the best practices and share with the stakeholders. With this, I will close this presentation, but we would love to hear your opinions through polls. If anybody interested to become a part of the study, we are very much welcome to collaborate. Thank you.
Thank you very much, Shree. This was very helpful to show how important the private sector is in engaging it, and how important it is to the clients and the patients, the TB patients, to their care and having patient-centered care by having access to TPT in the private sector where people prefer to have it, and incentivizing. So more broadly, I would like to summarize that across the board with these presentations, we have tried to show the audience, our experiences early implementing the rollout of shorter TPT regimens. And we have demonstrated that it is achievable and acceptable to expand access to TPT with shorter regimens, including 3HP. Across the board, there were hiccups along the way that we wanted to share with you so that you will learn, and maybe you will know how to navigate those based on our experiences. We still have some challenges, as presenters highlighted, and one, for example, challenge is that comes across that is more a global issue is TB infection testing. So we are still struggling with that. We hope that there will be simpler, more available, cheaper alternatives in the future to achieve that where it's relevant. And with that, I would like to ask my co-moderator, Dr. Maka, if she has any closing comments or has any further suggestions. We appreciate that we've gone over time and that you've stuck on with us, and I will close with that. Thank you.
Yeah, thank you very much for your attention and for listening. I think the only thing I'm going to say is that we are available for any follow-up questions. I see there were very specific clinical questions and some research questions in others. And at the Aurum Institute, we can follow up and help you with any startup or any expansion where we can benefit from the experience that we've had so far. So thank you very much. Bye.
Thank you, and we wish you a lovely rest of your day, evening, and morning. Thank you. Goodbye.